It's great to be back in Chicago for LSRS. By far my favorite meeting of the year, not only for the content, but just to catch up with so many good friends. So thanks, Scott and Rock, obviously, for the opportunity, and congratulations on a great ICL. So I'm going to try to give you kind of, I guess, what I'd call my 30,000-foot view on kind of how I approach this, and I think repetition is sometimes good, and there's going to be a lot of repetition of what kind of John just said, and I've actually learned a lot about deformity surgery from John over the years listening to him. So these are my conflicts, none of which are relevant to the contents of this talk. I think as deformity surgeons, sometimes we kind of like to say this, right, go big or go home, but not for every case, and that's really important. I think if you're doing deformity surgery, if you're not trying to encourage more people out of big surgery than you are doing big surgery, something's wrong, right? And so I think it's really important. This is a sweatshirt that my 11-year-old daughter made last year at one of her swim meets. It's like the most non-competitive, like goofy swim team in the world, and she picked 3 stickers, US flag, which I was proud of, go big or go home, which is obviously why I put it on here, and eat my bubbles. So I'm not really sure what that means, but that's what I usually say to Wellington. But anyway, so you know, the population is aging, and it's actually aging really, really quickly. So for all of us in the room who do spine surgery for a living, or if there's any joint people around, we're just going to get busier and busier, obviously, right? A lot of these patients will develop curves, right? So it's estimated that 30 to 50% of patients over the age of 65 will develop degenerative scoliosis. That's a huge number, right? Now, most of these patients have like clinically insignificant deformities. Some of these patients do develop significant pain and disability that's a result of their deformity. And this is a really common problem, right? So all the spine surgeons, all the APPs in this room will say, we see patients who come into the clinic like this every day. And I love John's first slide that he showed, because you could see these horrific kind of curves, and patients are like, my back doesn't hurt. Someone told me, you know, like, to come see you because I was standing a little funny, right? And so it's just amazing to me how some people tolerate their curves really well, but some people don't. And if you kind of think about complete versus limited correction, and again, a lot of this is kind of the same lines of thought that John was saying, like, all right, when can you do something small? When can you not do something small? And you're basically trying to do the smallest surgery you can to accomplish the goals of surgery, right? And like John said, sometimes those goals of surgery have to be big, unfortunately, because they have a big, you know, postural deformity problem. But these are the things that I think about, right? So is there a clinically significant deformity? And I know that may sound like a silly thing, but I think that's really important, right? Because so many numbers have come out over the past 20 years. It's really easy to start looking at these x-rays, measuring all these numbers and saying, oh, look, there's a little bit of a mismatch here, and you kind of turn into a deformity. But is the patient complaining of a postural problem, right? If they're not, it is really, really, really unlikely, almost unheard of, that I'm kind of going to, you know, think about putting that person through a big operation. What are their symptoms and sites of neurologic compression? Just like John was just saying, there's a lot of patients we see who have these like low lumbar fractional curves, who have an L4 and L5 radiculopathy, and oftentimes you can treat those with a small, short segment kind of operation. What are the potential risks and benefits of every operation that you can offer that person for their problem, right? You have to think about that, obviously. And then if someone truly does have a real deformity issue, can the patient tolerate a big operation, right? Kind of that sniff test. And if they can't, please don't offer that patient an operation. The only thing you're going to do is cause more problems than do good. Sometimes it's pretty obvious, right? So if you kind of start thinking about when do you have to kind of do a deformity correction, when do you have to do a complete correction versus kind of a limited correction, you know, sometimes it's obvious. A person like this, right, who's standing like this and who's truly debilitated, I don't think there's an option other than to address her deformity if she's clinically able to kind of tolerate that surgery. And some of these patients, I would actually argue most of these patients are happiest patients, because these patients are so miserable right before surgery that if you kind of get them ready for surgery and you get them through surgery and they do well without a complication, and I agree with John, the complication rates are really high, they're some of your happiest patients because they were so miserable before. But most of the time, I would argue it's not obvious, right? And for the trainees in the room, or really for everybody in the room, if this patient doesn't confuse you, then you're probably not thinking hard enough about your patients, I think, right? Because, you know, I see a patient like this, and she's obviously got a lumbar curve. For the most part, she's really pretty well balanced. She's got stenosis at 3 levels, at 2, 3, 3, 4, 4, 5, and I'm thinking to myself, oh God, what am I going to do for this lady, right? And if you kind of don't lose sleep over that decision-making process, then you probably have to kind of go back to the drawing board. So I kind of teach our fellows and residents, you know, always ask yourself, for any patient, but particularly for any deformity patient, like, you know, ask yourself 3 questions. What are the goals of surgery? That's really important, right? Is the goal an isolated neurologic decompression and stabilization? Well, that's great because that's a relatively small goal. Is it a big deformity correction? That's different. That's a bigger goal. What are the treatment options? And what are the treatment options? And you've heard this several times throughout this ICL. What are the treatment options, best treatment options in your hands? And it's going to be very different for all of us, right? Some of us are really good lateral surgeons. Some of us do a lot of posterior surgery. Some of us do a lot of anterior surgery like John. So always ask yourself, what's the best treatment options in my hands for this particular person? And then again, repetition, what's the smallest surgery I can do to accomplish the goals of surgery? I think that's really important for us to do. You're probably wondering why I have this slide up here. Obviously, the coronavirus, biggest pandemic probably of all of our lives, hopefully of all of our lives. But as spine surgeons, I would agree or kind of argue that there's probably another pandemic or epidemic that we're kind of dealing with right now. And I call it the T10 pelvis epidemic. And I think this is a real problem, right? If you look at kind of the number of large kind of long segment deformity operations being done in the United States alone, it's gone up 450% basically over the last 10 to 15 years, and that's kind of wild. And the biggest rise is patients over the age of 65, right? And so why the epidemic? And this is where it becomes a little bit kind of, gray zone here because, we've learned so much over the past 10, 15, 20 years, mostly out of the ISSG, about kind of what's important from a radiographic parameter standpoint and kind of what predicts good outcomes of surgery. But I also think that sometimes we kind of lose the forest through the trees or whatnot. And I think it's become a numbers game, and a lot of people are doing big operations just because of the radiographic parameters as opposed to really looking at the patient and kind of looking at what is the best option for that particular person. Everyone in this room understands kind of this lumbar lordosis index, the importance of regaining lumbar lordosis, particularly down low in the lumbar spine. The reason why I put this up here is because every operation is a deformity operation, right? Whether you're treating it, we're preventing it, or we're causing it. And unfortunately, I think, and all of us are guilty of this, sometimes we cause it more often than we'd like to admit. So to get back to kind of, the complete versus kind of like more limited correction, these are the things that I think are important, right? What's the patient complaining about? How much axial back pain are they having? Are they having a lot of settling pain? Does the pain get worse throughout the day? Are they having kind of rib pelvic abutment syndrome? Are they obviously having leg pain? Where's their neurologic symptoms coming from? And are they complaining about their posture? Are they fatiguing throughout the day because they literally just can't stand up straight anymore? All those things are really important to help kind of determine what are the goals of surgery to make sure that this patient does kind of as well as they want them to, right? What do the imaging studies show? I think the etiology of the curve is really important. Like, it's rare, at least in my practice, it's rare I'm doing an adult idiopathic scoli case that's like a big deformity correction. These patients have lived with their curves their whole lives. They're in their 50s, in their 60s, and they're usually relatively stable. It's really, really rare that I'm doing a big operation on an adult idiopathic curve. The de novo curves are the different ones. They're the kind of the bad actors, so to speak, because they tend to decompensate, I think. What's their global alignment? What's their balance? If someone has, like John was saying, if someone has a significant sagittal plane deformity, coronal deformity, I'm not sure if a small operation is going to really kind of accomplish those goals of surgery well. Are there significant comorbidities? We heard about that before. We're going to hear about that on Friday. It is so important, particularly in this patient population. So if there's significant comorbidities, you have to optimize those patients perioperatively before you even consider offering them a surgery. And then what's your skill set? And I don't mean necessarily just as a surgeon, but what's your hospital kind of set up to do, right? I mean, I think if you're kind of going to do a lot of big complex deformity surgery, you got to make sure that you're kind of working with your anesthesia team and basically everybody, right, to get these patients through surgery. So again, what are the goals of surgery? Does the patient have a deformity problem, or is it a degenerative problem that you can kind of do something relatively small with? And we talked about this a little bit, and John did too, about the deformity problem. Is there a significant imbalance? Is there a lot of kind of axial mechanical settling back pain? Do they fatigue because of their kind of postural issue? And is there rib pelvic abutment? If they have any of those things that you think are causing significant symptoms, then a small operation oftentimes is not going to be the answer. I think we have to be critical of ourselves. Failure of planning. I think there's unfortunately too much big surgery sometimes for small problems, and kind of obviously the execution part of it I think is really important too. So I'm running out a little time. I'm going to go through a few cases really quickly just to hopefully highlight some of these points. So this is a 67-year-old male. He's got moderate back pain. He's got severe left leg pain. He had improvement with a left L5 select nerve block. If you kind of look at his x-rays, his overall balance is pretty well maintained, right? He's got a little bit of a lumbar flat back, and he's probably flattening his thoracic spine just a touch. He's got really bad L5 foraminal stenosis. So I'd kind of argue for this person, what are the goals of surgery? What are the treatment options? And this person ended up having this operation for this problem. I think a lot of us would argue that at L5S1, operation alone probably would achieve the goals of surgery. Now, here's the thing: this guy's leg pain went away because it was part of the operation that they did. But I'm not sure, right, if that patient needed this operation, a T10 pelvis with a 3-level inner body fusion. This is a patient of mine who's a 68-year-old female, complained of severe leg pain, right greater than left. I apologize, I don't have the Scully films, but she's well balanced. She's got this curve. She's 68. She's got a spondy at 4.5. She's got 1-level stenosis, and kind of like John was talking about, I kind of said to myself, well, hey, if this were me or if this were my mom or my sister, what would I want? I'd want a 1-level operation, right? So I gave her the smallest operation I could probably do, which is a post-lateral fusion, right? Don't forget about post-lateral fusions. They actually work really well. And I saw this lady 6 years after surgery, and she still looks like this, and she's doing great. It kind of surprised me, to be perfectly honest with you. I thought she was going to break down at some point. But, you know, the other thing we don't talk about enough is probably how do we define failures in this versus short versus kind of long segment? Because if this lady did well for 4 years and then broke down and then needed another operation, I don't think that's necessarily a failure, right? Because if you do a T10 to pelvis right off the bat in this person, she fails, and then she has a T4, and then she fails, and she has a C2, you ruin that lady's life forever. You know, there's no question. This is a 62-year-old female with severe back pain, left leg pain, more significant curve, but overall posture is still really well maintained. Symptoms are worse with standing and walking. She can't really work as a pharmacist anymore. She's got really bad L4 foraminal stenosis. And the reason I show this case is because I tried probably 5 times to talk this lady out of a big operation to just take care of her radicular pain. But the more I saw her and the more I got to know her and her family and the more I got to understand her symptoms, I realized that's not what she wanted. Like she was having a lot of kind of this axial low back pain, settling pain. She had some rib pelvic abutment pain. And so we ended up putting her, I'll skip through that for the sake of time, through a relatively big operation, obviously, right? She's one of my happiest patients. She went back to work 6 weeks later, which was kind of a shock to me as a pharmacist. This is the one that I kind of wish I can have back, honestly. So this is a 64-year-old female who had back and left leg pain. This is the patient I showed before where I kind of like lose sleep over these patients because I'm not exactly sure what to do. Spondy at 4.5, most significant stenosis at 4.5. And I tried to do something relatively small on her. So I did a 2 to 5 with a 4.5 TLIF to address her foraminal stenosis. And John showed this paper that Greg Schroeder published, you know, kind of looking at short segment versus long segment. But this is a lady who kind of failed pretty quickly, unfortunately. She failed about 9 to 12 months later. She pseudoed at 4.5. She kind of started like having more of like this coronal kind of, you know, decompensation. And unfortunately, then I had to extend her up to T10. And so again, I'm not sure, from a patient standpoint, it's hard to go through a relatively big surgery and then have to go through another relatively big surgery in the short term. These are probably the hardest patients, obviously, to take care of. I'm going to skip through this just for the sake of time. You know, I think from my standpoint, you know, especially early in practice, ask yourself, is this a degenerative problem that I can take care of with a relatively small surgery, or is it a deformity problem? And I got 3 golden rules to leave you with. And this is Mike Dawes. Most of you guys know Mike. He said this one time, actually, I think last year at LSRS, you know, having a PI to L mismatch is not an indication to perform a big operation. Now, it doesn't mean we don't care about it. We care about it. And deformity surgeons kind of, you know, like obsess about this stuff. But it's not an indication to do a big surgery. This Cliff Tribune in his basketball days, most of you guys know Cliff. So I remember as a fellow, Cliff told me avoid fusing someone to the sacrum or pelvis like the plague. And this is coming from someone who does a lot of complex deformity surgery, right? So there's reasons to fuse people to the sacrum: symptomatic instability of 5.1, severe L5 foraminal stenosis, radiculopathy, real deformity correction, right? I think we see a lot of fusions to the sacrum and to the pelvis, probably for not great reasons. And this is what I'll leave you last. And I know it sounds kind of cliche and silly, but you know, ask yourself, what would you do, right? If it were you, your mom, your dad, your brother, your sister, someone that you love, I guarantee you're not going to put that person through a T4 to pelvis most of the time. So thank you.